For the biceps femoris, it flexes the knee, laterally rotates a flexed knee, extends the hip, and posteriorly rotates the pelvis. It's innervated through L5 to S2. It originates on the long head, originates at the ischial tuberosity. The short head originates from the lateral lip of the linea aspera. Both insert into the fibular head. The position is the patient would be prone. The stabilizing hand would stabilize the posterior pelvis. My resistance hand would be on the posterior distal lower leg, and I would ask the patient with their leg or their tibia externally rotated, I would ask them to bring their heel to their butt, and a compensation would be flexing the hip to gain leverage. For the semimembranosus, it flexes the knee, medially rotates a flexed knee, extends the hip, and posteriorly tilts the pelvis. It's innervated through L5 and S1. It originates on the ischial tuberosity and inserts on the posterior aspect of the medial tibial condyle. The patient position would be prone, stabilize the posterior pelvis, and resist at the posterior distal lower leg, and ask the patient to bring their heel to their butt with their foot internally rotated. A compensation would be to flex the hip to gain leverage. All right, for biceps femoris and semimembranosus, patient is laying prone, and for biceps femoris, I'm gonna have her point her toes out and pull her heel to her butt, back down. And I'm gonna stabilize the pelvis. I'm gonna have her do it again, go ahead. Good. Same thing on this side, toes out, pull your heel to your butt, back down, go again, pull, good. And then for the membranosus, toes in, same positioning, heel to your butt, good, back down, go ahead, good, toes in, heel to your butt, good, pull, good. For the best muscle in the world, the SARTORRRRRIUS, it flexes the hip, externally rotates the hip, abducts the hip, flexes the knee, and medially rotates a flexed knee. It's innervated through L2 and L3. It originates at the ASIS and inserts into the pes anserine tendon. The patient is seated for this manual muscle test. There's not necessarily a stabilization point because both hands are resisting. One hand would be at the anterolateral aspect of the distal thigh and the medial aspect of the distal tibia, and the patient would be asked to bring the tested foot into a figure 4 position, resisting the external rotation of the hip and the flexion and abduction of the hip with both hands. A compensation would be alright, for the SARTORRRRRIUS manual muscle test, I'm going to have her do a figure 4, so cross your legs. Good. Do the other one. Okay. And I'm going to resist distal lower leg and distal thigh, so go ahead, try and cross. Good. Next one. Go ahead. Good.